study also had these atypical non-cultural bacteria like Mycoplasma pneumoniae, which actually, numerically speaking, in this particular study outnumbered Strep pneumo. And so that's using acute and convalescent serologies to make this diagnosis primarily. With hospital-acquired pneumonia, the definition, just to remind everybody, is that the patient comes in to the hospital not having pneumonia, but after being in the hospital for over 48 hours, they then get afflicted with a pneumonia. And similarly, ventilator-associated pneumonia, or VAP, means that the patient was intubated for a non-infectious reason. It could be ultramentation, it could be for airway protection or COPD, for example. But after being on the ventilator for 48 hours, they then get afflicted with pneumonia. It is known that after day 5 of being in the hospital is when patients start getting colonized with these more typical nosocomial bacteria. In the United States, HAP and VAP are probably the most common infections seen in the intensive care unit, and responsible for up to 22% of all the nosocomial infections. And when patients do have either hospital-acquired pneumonia or ventilator-associated pneumonia, the mortality is seen to be higher than community-acquired pneumonia in the 20% range, up to 27% with ventilator-associated pneumonia. Historically, when we look at the microbiology and the sputa of patients with HAP and VAP, and this would also, by the way, also include nursing home pneumonia, which is basically the patient's never left the hospital. Historically, the gram-positive bacteria is not Strep pneumo anymore, but rather Staph aureus, including MRSA. Amongst gram-negative bacteria, historically, Pseudomonas was historically the most commonly isolated gram-negative bacteria, as shown in this table here, followed by Klebsiella usually second, and then we see a bunch of other gram-negatives, including Acinetobacter thereafter. Here are just some gram stains. This is, of course, of Staph aureus. This is a gram stain of Pseudomonas. Here's a gram stain of Klebsiella, and here's a gram stain of Acinetobacter. More recent clinical trials looking at VAP, though, have shown a little bit of a shift in the gram-negative bacteria. This one was called the APEX-NP trial, worldwide clinical trial comparing 2 different antibiotics for VAP. This study ended in year 19. But you can see in the more recent trials, though, Klebsiella has overtaken Pseudomonas as the most common gram-negative bacteria, with Pseudomonas and Acinetobacter taking second and third place close by afterwards. But Klebsiella seems currently to be the most common gram-negative nowadays, although we still see Pseudomonas and Acinetobacter. But you can see the microbiology of HAP and VAP are actually quite more varied, much more diverse types of bacteria, particularly in the gram-negative realm, with less predictable resistance patterns and less predictable susceptibility to antibiotics. I want to mention that viruses is probably an underestimated cause of pneumonia as well. Historically, I think everyone knew that influenza was probably the most common cause of viral pneumonias. In community-acquired pneumonia outbreak setting, it can be up to 10 to 20% of community-acquired pneumonias and up to 50% in epidemic type settings. Other viruses that are known to cause pneumonia, adenovirus, parainfluenza, I think a very underappreciated virus is RSV, respiratory syncytial virus. Coronavirus can also cause pneumonia, and I think it goes without saying that the novel COVID-19 virus, which was still actually causing problems even to this day, these viruses can mutate and then acquire enhanced virulence. The clinical presentation of viral pneumonias is actually oftentimes indistinguishable from the bacterial pneumonia in that it causes fever and cough and sputum production potentially. There can be some radiographic differences. Classically with viral pneumonias, you see more ground glass opacities as shown here in the CT scan. But historically, when people have a virus, they can actually put the lung at risk for having a really severe superinfection with the bacteria, very classically seen with influenza, where Strep pneumo is probably the most common superinfection with the bacteria after influenza, followed by Staph aureus. But group A strep pyogenes is not mentioned here, is also another cause here. In the United States, the Centers for Disease Control estimated that between years 22 and 23 after COVID-19, there were between 27 and 54 million cases of influenza, with up to 650,000 hospitalizations and up to 58,000 estimated deaths from influenza. Here's a case from our hospital where somebody came in with influenza, but actually had a superinfection with what turned out to be Staph aureus. You can see that the chest X-ray progression within the same day. This patient was rapidly intubated, was on pressors, and even with empiric, from the very beginning, empiric MRSA coverage, she ended up succumbing to her infection. So this is a case of influenza A with severe superinfection with Staph aureus. The challenge with pneumonias in general, and something that as an infectious disease specialist, I've always had a issue with is with the etiological diagnosis, the microbiological etiological diagnosis of the pneumonia. It's really probably the only infection where we have a site of infection, but we don't commonly get the microbiological etiologic agent of the infection from the primary site of infection. So we don't commonly get the answer to what's causing it from the sputum. In our hospital, anyways, oftentimes the answer was the cause of the pneumonia was actually through blood cultures, which, as you know, does not have a high sensitivity in pneumonia. But it's more commonly, we saw more common that strep pneumo grew in the blood than the sputum. So historically, in over 60% of the cases, there's been no microbiological diagnosis for pneumonias. 14% of 14% of cases are bacteria cultured. And this is for a variety of reasons. It could be because the patient's not producing good sputum. It could be because the antibiotics are already given by the time sputa is collected. Many bacteria are very fastidious after the first dose of antibiotics and will not grow anymore, particularly strep pneumo and H flu. There's also the issue of historically the time it took for us to grow the bacteria and identify the bacteria after the sputum is collected, up to 72 hours after admission. When we get the sputum, we plate it, incubate it, and then identify it. It can be by day 3 or so before we get the identification. Of course, the atypical bacteria like Mycoplasma, Chlamydophila, Legionella cannot be cultured, at least not easily cultured. Your laboratory has to have special media to culture Legionella. Viruses are not commonly tested for outside of pandemic or epidemic settings. I think most people do check for influenza during influenza season, but we don't routinely check for viruses in every pneumonia case. A lot of these non-culturable bacteria, we need to use acute and convalescent serologies and antibody testing to diagnose them, like we did in the study that I just mentioned. However, this is of a very limited utility in the hospital when you're actually seeing the patient and managing the patient now, because you don't have the luxury of having convalescent serologies. Specifically for Legionella, we do have a very commonly used urine Legionella antigen, but the sensitivity is in the 70 to 80% range because the antigen test only detects Legionella pneumophila serogroup 1, but not the other serogroups, and it doesn't detect the non-pneumophila species of Legionella. And if your laboratory itself doesn't perform this urine antigen test, then usually it gets sent out to a reference laboratory somewhere else, and the turnaround time can also take a long time as well. So it can be also of limited utility. Also, the empiric antibiotics we give for pneumonia, if you look at guidelines, this is looking at our IDSA, Infectious Disease Society of America, and the American Thoracic Society guidelines on what to use to treat communicable pneumonia. And there's a lot of assumptions and questions you got to ask, and there's a lot of guesswork being involved. For example, if the patient had a prior history of MRSA, should you give MRSA coverage or not? Well, it depends on how severe the pneumonia is. If it's not very severe, then you test for it, but you don't empirically treat for it. But if it's very severe in ICU, then you do empirically treat for it and then take it away. And same with Pseudomonas. You have to ask and look at the records to see if they have any prior Pseudomonas in the sputum or not. Maybe they're a nursing home patient. If they're not very severe, maybe you don't treat for it, but if they're severe, then you treat for it. So a lot of uncertainties are involved with communicable pneumonia treatment. A lot of assumptions are being made, a lot of ifs, ands, and record keeping. And the same can be said for HAP and VAP, hospital pneumonia and ventilator pneumonia, where if they're not as severe, then maybe you just give an agent that treats gram-negatives like piptazo or cefepime. You then have to factor in whether they may or may not have MRSA or not. And if so, then you might add something for MRSA like Vanco or linezolid. But if they're in a very severe setting, like an ICU type setting, then they ask you to give maybe 2 gram-negative drugs because 1 gram-negative drug may not be reliable for a more resistant gram-negative. And so you have to decide in your area what the percent resistance rates are. In most parts of the world, quinolone is really not an option, even though it's listed as an option here because of the high resistance rates in most gram-negatives, including Pseudomonas, to this particular pathogen. So there's a lot of guesswork that's involved. You can never be sure whether you're covering the right bacteria or not. Are you giving too much antibiotics? Do you really need to give vancomycin, for example, which can be a relatively renal toxic drug as well? So this is also another challenge that we have. And we know that the more antibiotics that we give in a particular region or in a hospital, the more resistance we see in bacteria, particularly in gram-negatives. We see that everywhere around the world, where we see rising resistance to quinolones, to cephalosporins, to carbapenems. The worldwide distribution of ESBLs, CTX is the gene type that's most commonly causing ESBLs nowadays around the world. Carbapenemases are also spreading around the world as well. In the United States, KPC carbapenemase is the most common. In other parts of the world, it's in the metallo-beta-lactamase classes like NDM, VIM, and IMP are the more common carbapenemases that other countries see. And so these, of course, all make the choice of antibiotics for a very sick patient very, very challenging. We also know that the more antibiotics we use in a hospital, the more resistance to the antibiotic that we see. And this has been shown over and over again. Here's on the left-hand side here, I show a study from Germany where they track the consumption of carbapenems with Pseudomonas resistant carbapenems. And you can see that they pretty much track each other. They almost overlap each other in terms of consumption and resistance. This is a similar study seen in Spain or done in Spain, tracking carbapenem usage and carbapenem resistance to Acinetobacter. And here's a study from the United States. This is from the Northwestern Hospital in the United States, looking at the carbapenem usage, ERTA, EMI, meropenem, and the amount of CREs, carbapenem-resistant Enterobacteriaceae, that they saw in the hospital. You can see, again, a similar trend. The more they use, the more they saw. So antibiotic use leads to antibiotic resistance. That's another challenge that we all have. Also, the other problem with, of course, antibiotic use, the broader the agents that we use and the longer we use it, the more likely the patient will develop C. diff, Clostridioides difficile. And C. diff is a problem, I think, in pretty much all hospitals with antibiotic usage. I show here an interesting meta-analysis study looking at, they collated together 7 studies on C. diff, looking at which antibiotics actually are, have a greater propensity to cause C. diff. And as you can see, interestingly, clindamycin is number 1, followed by broad spectrum cephalosporins and quinolones and carbapenems in the number 2, and the second most propensity to cause it. The broad spectrum cephalosporins are things like 3rd gen cephalosporins, 4th gen cephalosporins like ceftriaxone, ceftazidime, cefepime, things like that. On a lower risk scales, the penicillin, sulfas, and macrolides. And interestingly, in this particular meta-analysis, tetracyclines have a very low risk of causing C. diff. So what we know is that antibiotics alter the bowel flora, and our bowel flora is very important for our homeostasis and to maintain our health. And when we alter it, and when patients have spores of C. diff, that's when they can get this potentially life-threatening infection. So all this is to say that having judicious use of antibiotics is quite important. This is why in the United States, a lot of emphasis is placed on every single hospital having antibiotic stewardship programs. Here are some of our guidelines showing us how to best employ these stewardship strategies. But antibiotic resistance, of course, is not just a United States problem, it's around the world. And so the WHO and many other societies across the world are also warning about antibiotic resistance and promoting the judicious, appropriate use of antibiotics, making sure that we only use antibiotics when it's necessary and to use only the antibiotics that cover the bacteria that are causing the infection. One of the most important concepts in the antibiotic stewardship is streamlining or de-escalating, honing in the antibiotic on the actual causative agent causing the infection and not giving broad spectrum therapy for the entire duration of therapy. The problem with de-escalation, of course, is always that, can you identify the actual pathogen itself? That's always been a challenge, particularly in pneumonia. And pneumonia also, as I said earlier, there are non-culturable pathogens that may be causing the infection, which you can't culture out in standard media, like the typical bacteria, Mycoplasma, Chlamydophila, Legionella, viruses too. And of course, we also need the agent, the etiological agent, in a timely fashion early on when the patient first gets admitted, where we can actually make a difference when they're in the acute phase of their infection. And that's always, again, been a challenge in pneumonia, because when we use standard culture techniques, oftentimes we get the answer if we culture anything out, we get the answer usually around day 2 to 3 of admission, so several days into the admission. Also, for those of you in the audience that are involved in infection control, the bacteria that the organism, I should say, infectious organism that the patient has important implications in infection control, because certain organisms need isolation. I show here in a table of some common infectious agents which need both droplet and airborne. And droplet, for example, as far as pneumonia is concerned, Mycoplasma pneumoniae, and certain viruses will need, like influenza, will need droplet precautions or isolation. Airborne isolation is given for some of the more severe or known airborne pathogens like tuberculosis, for example, smallpox, avian influenza. And then, of course, during this COVID-19 pandemic, I think most hospitals were using airborne isolation for that. There's also, though, contact isolation that needs to be given for drug-resistant bacteria when the patient has it to prevent the transmission of these drug-resistant bacteria throughout your hospital. Bacteria such as MRSA, ESBL gram-negatives, carbapenem-resistant gram-negatives, whether it be in the members of Enterobacteriaceae, Pseudomonas, or Acinetobacter, are common contact isolation pathogens. Many hospitals employ empiric contact isolation for patients at high risk for these drug-resistant bacteria, such as nursing home patients, patients with chronic wounds, patients with a more recent history of multi-drug resistant bacteria isolated from somewhere in the body, like urine, sputum, or wound cultures. They will automatically get empirically isolated. And so these are where the pathogen identification is important for infection control. So now in the current age, I think we have better ways to both give care to our patients as well as doing infection control and antibiotic stewardship, because we're in the era of PCR testing now. I think pre-COVID, not a lot of doctors were quite as familiar with PCR testing in general, particularly in the respiratory, upper respiratory and respiratory realm. But after COVID, I think many people have some experience with it, but we've had these rapid multiplex PCR pneumonia panels for people with either community-acquired pneumonia or hospital-acquired or ventilator-associated pneumonia. And these are people, of course, that are able to expectorate a good sputum sample or undergoing a bronchoscopy. The runtime for these multiplex PCRs is usually around 60, 90 minutes, which means that if a sputum can be obtained even in the emergency room on the day of admission, then we can get the etiological agent before the patient even heads upstairs to the hospital. Here's a typical example of a film array pneumonia panel. You can see that this particular example, it can identify 33 pathogens, including all the bacteria that cause a community-acquired pneumonia, strep pneumo, Haemophilus influenzae, the atypical bacteria, Chlamydophila, Legionella, and Mycoplasma, but also the bacteria that causes VAP, HAP, like the gram-negative, Acinetobacter, Pseudomonas, E. coli, Klebsiella, etc., and Staph aureus. And it includes resistance genes, so it can distinguish whether Staph aureus is MRSA or MSSA. It could tell you whether the E. coli or Klebsiella is ESBL or not by the CTX gene. It also contains all the carbapenemase genes as well, the metallobalactamase as well as KPC, and the oxycylinase OXA48-like genes as well. It also gives you a semi-quantification when it reports the results to give you an idea about how much of the organism is in the sputum sample. And roughly the quantifications correlate to cultures as I show in this table here. So that 10 to the 5th correlates about 1+ growth, and 10 to the 7th or more corresponds about 3+ growth, and 10 to the 4th corresponds about rare growth. Generally, the PCR systems are more sensitive than cultures because cultures are affected by so many different things, including prior antibiotic usage, which can inhibit the growth. Studies have shown that these rapid multiplex PCR panels are very, very sensitive and very, very specific as well in identifying the organisms. Studies have shown that in BAL, 96% sensitivity, 90% specific. In good expectorate sputum, 96% sensitive, 97% specific. So that you can have the confidence that if a pathogen is not identified by the PCR, then it is not there. And it can oftentimes detect pathogens that are not shown in cultures because of usually prior inhibition by antibiotics, or because the overgrowth of other bacteria is hiding the actual pathogen itself. Here is a study that I show that was done throughout 48 academic medical centers throughout Europe and Israel, where they tested almost 2,500 sputum samples, and they compared the rapid multiplex PCRs with standard cultures. And overall, the standard cultures detected 57% of the pathogens, whereas the rapid multiplex PCR systems detected 96+%. As far as viruses are concerned, their standard techniques detected viruses in 20% of the samples, whereas the rapid sputum PCRs detected 98% of them. And if you go down this table here, you can see that for each bacteria, in the black is the PCR, it always identified that bacteria more often than the standard of care, the culturing systems, which is shown in the gray. So for all the bacteria that's shown here. We were one of the test sites for one of these rapid multiplex PCR systems in our laboratory when it was being studied. And so upon noticing that the utility of it, we started to use it clinically in many of our patients. And so we actually presented our experience with it back in 2019 at our ID week in Washington, D.C., right before the pandemic. Here's the title of the poster. And we subsequently published these results in the Journal of Infectious Diseases. And what we saw was that the sputum concordance between our PCR and the cultures was around 25%, where the PCR was able to identify bacterial pathogens in 32% of patients, and in 21% of patients with viruses that were not identified by conventional methods. And so when you look at the patients with negative standard of care workups and negative cultures, these are the bacteria that we were able to identify by PCR that we were not able to identify by cultures: Staph aureus, Strep pneumo, H. flu, Enterobacteriaceae, Pseudomonas, and there was one case of Legionella. And again, a lot of these cases where the cultures basically just show normal flora, and so the clinician did not have any data to act upon it. The culture growth was really just inhibited by prior antibiotic usage. By the time they submitted the sputum sample, they were not able to grow out the bacteria. And the PCR systems did not miss any pathogens that was identified by cultures. When we were prospectively using these PCR methods, we found that in 100% of the cases, we could actually intervene on the antibiotics that was being given. So you can see here in the table all the stuff that we did on the ones that we were able to intervene on. Most commonly, we were able to DC or discontinue antibiotics when it didn't show the offending pathogen, like Pseudomonas, like MRSA, like atypical for azithromycin. In this publication that I show here, this was a publication done by 8 United States hospitals, including UCLA Hospital and as well as Children's Hospital of Los Angeles. And they had analyzed 259 BAL samples with the PCR system, and then went back into the patient's chart to see potentially, theoretically, what could they have done. And they found that in about 71% of the cases, they could actually intervene and do something to the antibiotics to optimize it. Most commonly, in about half the cases, they could de-escalate or discontinue antibiotics. And then second most commonly, they can prevent the inappropriate escalation or continuation of antibiotics. And on the right-hand side, you can see the type of antibiotics that they theoretically could have de-escalated or discontinued. Most commonly vancomycin, followed by the anti-pseudomonal drugs like Peptazo or meropenem. So this was something that they showed something that they showed on a more theoretical scale, but with more samples. But it was in sync with what we were prospectively already seeing in our publication. Currently, we're actually at our hospital, Olive UCLA Medical Center at hospital. We're currently investigating exactly the time to optimal antibiotics, time to optimal therapy for the patients based on the PCR results. We presently have enrolled almost 200 patients with, I think, a goal of 250. So we're almost at the goal here, and then we will present our data, I think initially in perhaps one of our national conferences, followed by a publication. Looking at it a little bit of a different way is shown in this study here. This is a study done in Switzerland where they looked at the BALs on patients, and they randomized people with BALs to either getting a PCR or standard of care, which is usually just standard cultures. And what they were looking at was that after they got the PCR results, they gave the recommendations of what to do for the patients antibiotic-wise 5 hours after the BAL was sent to the laboratory. And what they found was that inappropriate antibiotics were shortened by 38 hours with the PCR, with a mean duration of inappropriate antibiotics being around 47 hours versus 85 hours for standard of care arm. And they were able to decrease the duration of inappropriate antibiotics by 45%, as shown in these graphs here. As far as infection control is concerned, being able to rapidly, even on day of admission, identify multi-drug resistant pathogens that need isolation will allow your infection control department to isolate patients much, much more rapidly, even on day of admission. Alternatively, if your hospital has protocols for empiric isolation, for example, a nursing home patient, prior history of drug-resistant pathogens, then you can de-isolate much sooner if you do not PCR out that pathogen. Here's a study from South Africa where they're checking sputum again with the PCR systems versus culture, and you can see that the PCR systems were able to rapidly identify some of these drug-resistant bacteria, CTX's ESBL bacteria, NDM, and OXA or carbapenemases. Actually, it detected these multi-drug resistant bacteria in several cases where the culture methods did not detect it, which is important for infection control. But again, these were done oftentimes days in advance of standard cultures. So can really be a powerful tool in infection control, both for isolating patients rapidly and also de-isolating patients if they do not PCR out the drug-resistant organism if they had a history of drug-resistant organism or come from a nursing home. In applying these PCR systems in clinical applications, it should really be integrated as part of the antibiotic stewardship team, who can then rapidly get the results, act upon it, and make recommendations to the primary treating doctors. The microbiology lab, for example, can alert the antibiotic stewardship team when they receive a sputum sample whether they should run the film array PCR systems on it or not. If the sputum culture, of course, is good, the laboratory can determine the appropriateness of the sputum culture. BALs, of course, and mini BALs from ET tubes are good samples, always good samples. Some hospitals can integrate as part of an electronic order set. For example, if you order sputum culture, it may ask you automatically, do you want to also run a PCR on it, for example? And then the results can be sent to the antibiotic stewardship team, or the team can check daily on it. The infection control department can communicate with both the microbiology lab and the stewardship teams about isolation procedures. And these PCR systems can be used on really any patient severe enough to be admitted, including people in the severest cases of severe sepsis, septic shock in the ICU type setting. You can even have hospital protocols or algorithms on what to do with the results. I'll give you some examples here. For communicable pneumonia, for example, the patient is oftentimes given a beta-lactam and a macrolide or a tetracycline for atypical coverage. At least that's what's in the United States. If you run the film array PCR panel on it in 69 minutes, you'll get the answer in the sputum. If there's no atypical bacteria isolated out and there's only the strep pneumoniae flu, then you can just continue the beta-lactam and DC the macrolide, discontinue the macrolide or the tetracycline. If the patient had a PCR out in typical bacteria like Legionella, Mycoplasma, or Chlamydophila, then you can discontinue the beta-lactam. And if they have Mycoplasma pneumoniae, you can do droplet isolation for infection control purposes. If they have a virus identified in the sputum, you can add also tamivir for influenza, and then of course put them in droplet isolation for that as well. So this is a typical algorithm example for communicable pneumonia on how to effectively use the PCR panel. This can also, though, be developed also for hospital-acquired valent-associated nursing home type pneumonias. Commonly is an anti-pseudomonal beta-lactam and MRSA antibiotic being given empirically here. If you can get the sputum, and then you can then run the film array, the PCR panel, in 69 minutes, you get the answer. And there's several things that can happen. If no MRSA is PCR'd out, then you can, of course, discontinue the MRSA antibiotic like vancomycin, which can be, of course, relatively renal toxic. If there's no Pseudomonas acinetobacter or any resistance genes PCR'd out, then you can discontinue the anti-Pseudomonas beta-lactam or carbapenem and start instead of third-gen cephalosporin. If there is Pseudomonas, you can then ask whether the patient has a history of drug-resistant Pseudomonas or risk factors of drug resistance. And if there is, then you could potentially escalate the Pseudomonas therapy to something that can cover more drug-resistant Pseudomonas like ceftolozane, for example, or ceftazidime or cefidrocol. And of course, you want to empirically put them in contact isolation for infection control. If they don't, you can continue your current anti-Pseudomonas therapy. If Acinetobacter is PCR'd out, then again, you want to ask if the patient has risk factors or have a history of having drug-resistant Acinetobacter. And if it's yes, then you want to escalate therapy against drug-resistant Acinetobacter. Some examples here: cefidrocol, high-dose sulbactam, maybe a second-generation tetracycline like tigecycline or eravacycline, for example, and also empirically initiate contact isolation. If no, then you can continue the carbapenem, maybe high-dose sulbactam as well. If a KPC gene a carbapenemase gene is PCR'd out, then change to an agent with a KPC inhibitor in it, like meropenem vaborbactam, ceftazidime, for example. If there's a metallobalactamase, which again is seen probably more commonly around the world in the United States, VIM, IMP, NDM, then again change to an agent that might cover metallobalactamase like cefidrocol, maybe also one of the second generation tetracyclines as well, tigecycline. So this is not the only algorithm, but an example of an algorithm that can be done to take full power of the film array PCR systems. I just want to give you some examples of some notable cases that we've had in our hospital. Here's a 54-year-old man admitted for fever, cough, myalgias, headache, confusion for about 3 days. This is his chest X-ray and CT scan, diagnosed with communicable pneumonia. We ran a multiplex PCR system on his sputum on the day of admission. It was positive Legionella. His beta-lactam ceftriaxone was discontinued on day of admission. He was only continued on the macrolide. He was discharged really the following day. Interestingly, the urine lesion antigen was negative, so we wouldn't have diagnosed it via the conventional urine lesion antigen way. This is this follow-up chest X-ray after just getting the macrolide by itself. So the novel practice points here is that we had a very rapid Legionella diagnosis, early de-escalation from the beta-lactam, early discharge, and gave the appropriate therapy for a duration that we probably would not have done as long of a therapy for Legionella had we not known it was Legionella. Another example here, a 67-year-old man with a history of ALS, chronic kidney disease, diabetes. He's from a nursing home. He was admitted for shortness of breath, cough, nausea, and vomiting. He was diagnosed with nursing home pneumonia. Here's his chest X-ray, and it became rapidly worse, as you see here. It was progressing really within the same day. His blood cultures grew strep pneumo. His nasopharyngeal influenza and RSV PCR was negative. But because he was getting worse and he went to the ICU and he was down on pressors, he was intubated now, the ICU team brought in the patient to vancomycin and cefepime, even though the blood cultures grew strep pneumo. So we knew that strep pneumo was the cause of his pneumonia. However, given the severe state that the patient was in, the ICU was kind of fearful of just leaving him on just strep pneumo coverage. So want to cover for everything that you might see in a nursing home potentially. The sputum culture, interestingly, grew normal flora. So we ran in the same day that they brought into vancomycin and cefepime the multiplex PCR system on it, and it was positive for strep pneumo, as expected. His blood cultures grew strep pneumo, but no Pseudomonas or MRSA, and also influenza A, surprisingly, even though his initial screen was negative. He was promptly the same day that they instituted vanco and cefepime, went back down ceftriaxone again. He went to droplet isolation, and then also oseltamivir was started. As many of you know, for severe influenza, there has been data showing that even after 48 hours, it can be life-saving to give oseltamivir. So the novel practice points here is that there's a prevention of unnecessary antibiotic escalation driven by fear and distrust of standard sputum cultures. Here was just normal flora. A viral pneumonia was not recognized by the traditional nasal swab, which has a lower sensitivity than sputum PCRs for viruses. And also oseltamivir would not have been given if we had only used the conventional methods. The final example I'll give here is a 67-year-old woman with cerebral palsy. She's on a chronic trach and vent in a G-tube, also from a nursing home, with hypotension and hypoxia. She was very febrile, 42.5 Celsius, and very tachycardic. She was admitted to the ICU for septic shock with nursing home pneumonia as a diagnosis. Here's a chest X-ray and the CT scan. The patient was empirically started on meropenem and amikacin. We ran the film array panel that you see here, and you can see these bacteria grew out, PCR out from the sputum. Acinetobacter, Pseudomonas, Proteus, Serratia in particular. If the KPC gene was detected, of course, the drugs that were given wouldn't be the optimal ones to be treating all of these bacteria that you see here. So this patient was changed to a drug called cefidrocol, which would cover all of the above. Here's what actually grew out, and you can see that the two Klebsiella and Serratia were KPC-producing organisms. It was meropenem resistant. The Pseudomonas and Acinetobacter are also highly drug resistant. You can see there, the Acinetobacter is an XDR, extensively drug-resistant bacteria, but it was susceptible to cefidrocol. So she got placed, luckily, on the proper antibiotic on a day of admission, which otherwise wouldn't have been the case. Probably we wouldn't have figured this out until realistically day 4 or 5 of admission. In the ICU, she probably wouldn't have survived. So the novel practice points here was that this patient got immediate data on extensively drug-resistant pathogens leading to antibiotic coverage that would normally have occurred on day 4 to 6 in a critical patient. And we were able to initiate early contact isolation from an infection control standpoint for the extensively drug-resistant pathogens, particularly the KBCs. As far as oral transition is concerned, I think we always want to give an oral drug whenever feasible and capable, regardless of the original severity of the pneumonia. For gram-positive bacteria, we do have very good oral options, drugs like linezolid, trimethoprim sulfa, tetracyclines for MRSA, for example. But for gram-negative bacteria, though, there are very few oral options. Quinolones probably is the best oral drug class for gram-negatives, but there's a lot of resistance around the world. In the United States, sulfas is not any better, and the oral third-gen cephalosporins also has a lot of resistance as well. If you have Acinetobacter, then minocycline might be an option, but minocycline is not universally active against all resistant gram-negatives, though. And so sometimes these extensively drug-resistant gram-negative bacteria just need the intravenous therapy for the duration of therapy. But assuming there's an oral option when the patient is improved or stable after their hospital stay, and when the susceptibility testing are back, then we can transition to oral therapy to finish up the therapy if feasible. So in summary, I think what I've hopefully shown here is that now that we have these rapid multiplex PCR systems that can be done in 69 minutes, it's really a major medical diagnostic advancement. It really increased our ability to diagnose pathogens and pneumonia. increases our ability to diagnose viral pneumonias. If we can have very rapid optimization and de-escalation antibiotics and put the patients on the correct antibiotics, oftentimes on the day of pneumonia diagnosis, including the day of admission, is also so crucial in our infection control measures in regards to isolation, rapid isolation, or even de-isolation. And it's a paradigm shift to something that people are not used to, but it's really our jobs to change the practice of this empiric broad spectrum coverage for pneumonias that's currently being recommended by our guidelines that I showed you, that we can actually do things and change things really on day of admission nowadays, assuming the patient can produce sputum, such as omitting the routine macrolide coverage in the United States we give for communicable pneumonia, the MRSA or Pseudomonas coverage for hospital carbamazepine-associated pneumonia as well. And it's really just a revolutionary tool for antibiotic stewardship and infection control. That is my portion of the lecture. I think we'll have some time for questions toward the very end, so I'm going to stop sharing my slides here.
Thank you, Dr. Zheng, for the very informative and excellent presentation. So talking about the etiology of the CEP plus, the diagnosis criteria using the regular culture and the PCR, especially the PCR, the algorithm for using the PCR protocol to diagnose bacteria, virus, and other micro biology, detection. So that's it's very helpful, for the CEP diagnosis and the precise treatment. So later on, we have a panel discussion. So there are a couple of questions for Dr. Zheng. Thanks again, for the excellent presentation.
You're welcome.
So now I introduce the second speaker, Dr. Hiroki Saito. Dr. Hiroki Saito is currently a consultant World Health Organization in Switzerland. He is also an assistant professor at St. Mariana University School of Medicine in Japan, from Yokohama Seibu Hospital Department Emergency and Critical Care Medicine. So welcome, Dr. Saito Hiroki, to give the presentation.
Hi, Dr. Song. Thank you very much for your introduction. Let me share my slides. Oops. Is it looking okay?
Yes.
Great. Sorry. So Dr. Zheng's talk was quite extensive about the clinical management and the infection control of lower respiratory infections. So I will shift my gear a little bit towards the more of a bit of public health issues, because I used to work on the Ministry of Health in Japan, and also I used to work for WHO. So here's my disclosure. So this is the recent Japan National Action Plan, NAP on AMR. So like the global action plan on AMR, we have covered 6 areas, including public awareness and education, surveillance and monitoring, infection prevention control, antimicrobial stewardship, and research and development. And plus, we have additional component as an international cooperation. So I think this kind of webinar will be very, very fruitful for us as well. And here is the previous Japan NAP from 2016 to 2020, with focus on human-related outcome measures. As you know, MR is commonly taken as a One Health approach. So this is just part of human-related outcomes. And as you can see here, we set out some goals up to 2020, and then in terms of antibiotic consumption, we kind of, we were very close to the goals by the end of 2020. But compared to that, resistance of bacteria, we didn't perform well. Of course, there may be a lot of, speculation, etc. I'm not 100% clear about the, causality and relationship between these two. But here's the updated Japan NAP from 2023 this year up to 2027. And then, as you can see here, there are 2 new measures, including VRE, vancomycin-resistant enterococci, and the other one is on intravenous carbapenems. And then on the right side of the column, you can see the goals by the end of 2027. And then in terms of antibiotic consumption or antibiotic stewardship, I just wanted to highlight some characteristics in Japan. So this is a paper comparing multiple countries on antibiotic sales. According to the WHO AWARE classification, particularly AWARE access category among the AWARE category is essentially like first choice with a narrow spectrum and a very good safety profile. But you can see here in the middle of this bar graph, Japan consumed compared to watch category. The proportion of the proportion of access category is quite lower, like less than 20%. And then we consumed lots of third-generation cephalosporin, oral cephalosporin, macrolides, and fluoroquinolone, which are commonly used for common colds like a respiratory infection. And then, as I mentioned, we also set the goal for IV carbapenems. I will talk a little bit about carbapenem issues in ICU settings like I currently work. So the left side is from Diana study covering 1,500 adult patients in ICU, more than 100 ICUs across the globe, including Asia and Japan. And as you can see here, 26% of patients were on carbapenem use. And then there was no de-escalation within 3 days among 63%. So it's quite a lot. People were never get de-escalation. And then the right side, it's an observation study from about 50 ICUs in Japan. And as you can see here, carbapenem it's the third commonly used antibiotic. And also now we had a COVID-19 pandemic, and then this is the data from WHO. As you can see here, depending on the regions, there are a substantial proportion of COVID-19 patients who were on antibiotics. And then we are in the bottom of this bar graph, WPRO, and then interestingly, we are quite well compared to other regions, and then only 33% of COVID-19 patients were on antibiotics according to this WHO data. And also, when I was working for the Ministry of Health, we also developed clinical guidance for antimicrobial stewardship with focus on common colds and diarrhea, because we know that common colds and diarrhea, the clinicians often use antibiotics. And then we made some statement. There's some like translation issues, but we said clinicians should not prescribe antibiotics instead of just making a do not recommend statement. So this was a quite strong statement as the government document. So in summary, Japan NAP on AMR was updated just recently. And then we realized that there were suboptimal trends for MDROs, multi-drug resistance, and oral third-generation cephalosporins, macrolide, fluoroquinolones were still commonly used, mainly for respiratory infections, and the carbapenem use was added as a new important indicator for Japan NAP, but still many ICUs use carbapenem commonly, and it's hard to de-escalate. And also viral respiratory infections like COVID-19 may compromise antibiotic stewardship. This is the end of my slides. Thank you very much for listening.
Thank you, Dr. Saito. So a very quick and excellent summary of antibiotics in Japan, and also from the global view, antibiotic resistance. So showing, so due to the other bacteria, due to the COVID-19, there could be, some of the changes of the antibiotic resistance, but still, following the high consuming of the antibiotics, so there's significant increase of antibiotic resistance, so which is a very severe challenge to the clinical practice. So thanks Dr. Soito and Dr. Jing for the excellent presentation on these two topics. So following we have a panel discussion, so we have a couple questions. So for Dr. Jing, there's two questions. So first is, could you take us back to the beginning of the implementing pneumonia panel at Oliver VU UCLA Medical Center? So how did you determine the testing algorithm of pneumonia panel together with the lab, as well as the result in interpretation, such as sputum in particular? The second question is, what type of education for the physicians have you introduced to assure successful implementation in clinical department and to maximize the patient access to better care? So Dr. Jing.
Thank you, Dr. Song. So taking the very first question about the beginning when we were initially implementing the pneumonia panel at our hospital. So what happened was that, as I mentioned in the lecture, we were actually one of the original test sites for the panel. This is at a time period when I think doctors in general have really had no experience with using these pneumonia panels for the diagnosis of pneumonia yet. And so what our lab was doing was comparing the cultures with the PCRs and looking at the correlation. But while they were doing that, when the lab was doing it, they were just randomly picking sputa that were being sent, but not specifically directing the testing against clinical patients. And so we noticed that, and then we saw that the excellent results that the PCR panel was giving. And then we thought, hey, this is something that can really address a huge hole in our diagnostic capabilities in pneumonia. That was, as I said in my presentation, one of the few infectious disease states where we oftentimes don't get the answer what's causing it. So we have to keep on giving this, empiric antibiotics. And so we started to then direct the testing after that. And then it was purely at the direction of the infectious disease, the ID's consult service, infectious disease consult service. So it was those of us that had a particular interest in it that were doing stewardship. So we knew normally what we would do when we would see, say, X, Y, and Z in the sputum culture, what we would do as far as discontinuing antibiotics, which antibiotics to put the patient on if you identify the bacteria, as far as honing in on the antibiotics, right? And we were doing the same thing with a PCR panel, just a lot earlier, days earlier. Again, sometimes on the day of admission or the day of diagnosis as well. And so I really think that the most effective way to use these types of rapid diagnostics, given, I think, in general, the lesser familiarity in general with the general physician on it, is to have it be done in conjunction with the antibiotic stewardship team who know what to do with the results. I think if you look in the literature out there, you will see that with any rapid diagnostics for anything from blood cultures through anything else you name, the value comes when there is notification and recommendation that comes from a stewardship team of what to do with the rapid results. I think if you just do the rapid test and just report in the computer system and kind of just do nothing more about it, nothing really happens too much in regards to the actual care of the patient. And so, that's continued to be our algorithm in regards to what we do. What happens is that the lab contacts our antibiotic stewardship team when they get a sputum culture that lands in the laboratory itself, and asks us whether we want to run the PCR panel on it or not. And what happens is the stewardship team will go into the chart and see if this is a patient where we do suspect pneumonia as a true diagnosis. And of course, we want to make sure that the sputum sample is a good sample and not just saliva, which the lab can do by looking at the epithelial cells. And so then then we tell the lab whether to run it or not. So that's what we did as far as the testing algorithm. And so really it's been our stewardship team that's been kind of taking the lead as to, what to do with the results and interpretation. Remember, I had mentioned also that this PCR system does give you a semi-quantification. It can tell you the 10 to the nth amount of the bacteria. And I think some people had the question about whether it might catch colonizers, and how do you distinguish them? And that's always been a problem, even with cultures. When you identify multiple organisms, you have to be able to use clinical judgment in terms of which of these are going to be actual pathogens and which of these may be just colonizers. But we tend to pay more heed to traditionally culture results with a higher growth, 4+, 3+, etc. And you get the same sort of a quantification with these PCR systems. So I wouldn't say that the PCR systems, I mean, perhaps the same challenges are there as far as if you have multiple pathogens, and if some of the pathogens may, for example, be just on the ET tube of the ventilator and not necessarily be in the lungs itself. A lot of it also depends on the type of samples that you get. So a mini BAL, even if somebody's intubated, even if you don't have a bronchoscopy, put the catheter down the ET tube, do a mini BAL with saline suction. That should be a very good sample. It should avoid the problem with colonization. As far as the question number 2 about what type of education, there's a lot of fear, I think, of the unknown initially. And so we had to really initially educate the attending physicians, the faculty physicians first, particularly in the ICU type setting where we're using this a lot to get them used to it. After that, a lot of the education was done by our stewardship team. When the results were done, we would educate the clinician who's taking care of the patient and what it means. And I think that there was more of a maybe fear and of uncertainty prior to the COVID-19 pandemic, when people just weren't used to PCR systems, and they not necessarily trust it. But I think now, after the pandemic, I think most people have had very lot of experience with PCRs in that they can persist even after therapy. They can persist for a while. You don't have to have live organisms to identify it. It's a very, very highly sensitive test. So nowadays, I think that the acceptance is quite prevalent, I think. So it's not too much of a problem so much anymore. But yeah, education amongst attending physicians, and then in our teaching center, the house staff thereafter, it actually probably occurs on a daily basis still.
Okay, thank you, Dr. Zheng. Especially, you clarify, the concern for the multiplex PCR. When we detecting, multiple, bacteria, microflora, so how to differentiate, whether, the pathogen detected is a true, the pathogen induced the pneumonia, or it's just in microflora in the colonization. So I think the PCR result, together with the clinical presentation, such the imaging and the color of the sputum, the neutrophils, if they combine, the PCR detection result with the clinical presentation, that may help, to differentiate whether it's colonization or it's a true microorganism. Thanks a lot, for clarification, for this issue. So there's another question for Dr. Saito. So in the post-pandemic AMR era, so what's your view regarding the utility of the rapid syndromic testing in supporting the national action plan of Japan, or optimal use of antibiotics?
Yes, thank you for asking, Dr. Sung. So yeah, I would say I can talk about 2 different things, one for hospital setting and then the other one for outpatient setting. And let me focus on the inpatient hospital setting first. So I would say, in the hospital setting or hospital's patient, we tend to use antibiotics of reserve and watch category of antibiotics quite often. So that, like Dr. Zheng's presentation, I think there is a quite good utility of rapid syndrome testing, so that we can de-escalate our antibiotics quite well, including carbapenem. And then for example, in Japan, like I told you, carbapenem is the it's a quite important target for National Action Plan, and then that can be de-escalated with use of rapid syndrome testing. And in terms of in the outpatient setting, I can totally echo Dr. Zheng. I think many clinicians are now used to rapid testing, even in the outpatient setting. So let's say we know that antibiotics, 90% of antibiotics are oral antibiotics and commonly prescribed in the outpatient setting. And then they are now better understanding the utility of rapid syndrome testing, so that that can be also utilized in the outpatient setting. Maybe try not to prescribe antibiotic in the first place to decrease or enhance antibiotic stewardship in the outpatient setting. Thank you very much.
Thank you, Dr. Saito. I think it's important, to use antibiotics more restrictively, especially, if we know the true organism, using the multiplex PCR or other, assay, if we have a precise detection microbiology. And so it's better, to use, antibiotics to target the specific pathogens. So otherwise, I think it's more antibiotic use. Definitely, there's more antibiotic resistance occurring. So, so thanks a lot, for both of you, for the answering of these 3 questions. There's a couple questions from the audience. I think some of them is already answered by Dr. Zheng. For example, we have recently seen, or in case of HAP, when resistant genes are detected by film array panel, we don't know if those genes come from the true pathogens or from colonization, especially in ICU patient. I think Dr. Zheng already clarifying, these issues. Another question is, will you see it maybe as risk to de-escalate too quickly? If so, when will you recommend for antibiotic de-escalation if patient is stable? Do you have any comments, Dr. Zheng?
So as far as de-escalation is concerned, we've never been able to do it in any sort of a rapid fashion before, because on day of admission, nobody knew what was causing the pneumonia. We've never had the ability to figure out what was causing the pneumonia, either it's community acquired pneumonia or hospital acquired ventilator pneumonia. We never had the ability to do it, to diagnose it. So therefore, we've not in the past had the experience of, on the day of a diagnosis, to put them on the best and optimal antibiotic that's only targeting what's causing the pneumonia. So now that we can do it, we should do it. And that's what we've been doing for the last several years. Again, it's going to take a little bit of a paradigm shift in terms of how we practice medicine, I think, around the world. Because around the world, everyone's so used to giving broad spectrum antibiotics for the first 2 or 3 days of anybody who's sick, right? And then it takes about that long for any of our cultures to grow out. We've never had the capability for figuring out what is causing the patient's severe sepsis, septic shock in the ICU on the day of admission. But now we can. And now that we can actually place a patient on the best antibiotics and de-escalate them as soon as possible. A lot of times, by the way, our broad spectrum antibiotics really aren't the best antibiotic for what's causing the infection. It's broad, it may cover it, but it's not the best. If we can get them on the best antibiotics, such as, just to give you an example, let's just say the patient has MSSA as the cause of the infection. Well, who has the patient on the best MSSA drug on day of admission? Rarely does anybody have that luxury, right? They have them on some MRSA drug, which is not the best MSSA drug. They have some broad spectrum beta-lactam, which is not the best MSSA drug either. But now if you figure out that it's just MSSA, you can put it on the best drug. So it's something we can do now with the technology of these film array PCR systems now. And I think we should do it as soon as possible. And not in other words, not when the patient's stable, but actually probably it's more critical when the patient's the sickest.
Yeah, I totally agree with you, Dr. Zheng. So when we do not know, the particular pathogens causing the pneumonia, so really, empirical, antibiotic regimen will be applied. As long as we know the particular pathogens identified, either the PCR, NGS, or for molecular biology, as long as we know the particular pathogens, I think so. This definitely, we could, move, from the, broad spectrum antibiotics to, de-escalation to using specific antibiotics that could, for sure will reduce, antibiotic resistance, for the field. So I think I totally agree with you, the opinion. So thanks a lot. So due to the time limit, so now, I will welcome Dr. Chia, the Vice President of Medical Affairs, ASPAC, the BioMaria, for the closing remark. Dr. Chia?
Yeah, thank you. Thank you to Dr. Cheng and Dr. Saito for the great presentation during this webinar. I also want to thank Dr. Lam and Dr. Song for moderating the session. BioMaria is happy to sponsor this educational event together with the Asia Pacific Society of Respirology. As you can see, this is a very important topic, and I wish we could have more time for the audience to ask and discuss other questions. Clearly, rapid diagnostic tests are important for the detections of pathogens causing pneumonia, so that the patients can receive the appropriate antibiotics. On a wider scale, the use of a rapid diagnostic tests can prevent the rise of antimicrobial resistance and help with the antimicrobial stewardship for the whole society. I hope the learnings and knowledge which you learned today will help your patients and enable them to live a healthier life. Have a good evening to Dr. Zheng. I know it's quite late in LA. And also for the rest of the participants in the Asia Pacific region, have a good day ahead. Thank you.
Thank you, Dr. Chia, for the closing remarks. Again, I will thank Dr. Jing and Dr. Soito for the excellent presentation to clarifying, the importance of antibiotic resistance together with, the targeting therapy based on the multiplex PCR detection of the microbacteria. So I think it's a very informative and excellent presentations. Also, I thank Dr. David Lam, for the opening remarks, and thanks BioMaria for supporting the APSR webinar. I think that's all the time we have for today. So we may see you soon in our next webinar. So I will ask the attendees to complete the post-webinar survey through the link posted in the chat box. Thank you again for joining us, and have a great day. So bye. Thank you.